Welcome to This Week in Critical Care. This week we are covering 8 notable papers spanning advanced life support strategies, precision medicine in sepsis and infectious diseases, and perioperative organ protection. Let's dive in. We begin with major updates in how we manage acute respiratory failure, from non-invasive interventions to extracorporeal support. The American Journal of Respiratory and Critical Care Medicine has published a comprehensive clinical practice guideline from the American Thoracic Society on non-invasive respiratory support. Using the GRADE approach and drawing on several systematic reviews and network meta-analyses, a multidisciplinary panel addressed key questions regarding high-flow nasal cannula, non-invasive ventilation, and continuous positive airway pressure. For adult patients with acute hypoxemic respiratory failure, the panel issued a strong recommendation for high-flow nasal cannula and a conditional recommendation for non-invasive ventilation or continuous positive airway pressure, emphasizing the critical need for close monitoring and prompt escalation if the patient's condition worsens. When dealing with acute hypercapnic respiratory failure, the guideline makes a strong recommendation for non-invasive ventilation, which has been shown to reduce both mortality and the need for invasive mechanical ventilation. Interestingly, they offer a conditional recommendation for high-flow nasal cannula in this population, but only for patients with less severe hypercapnia and mild acidemia, specifically defined as a pH greater than 7.25, and only if close monitoring and immediate escalation to non-invasive ventilation are available. For preoxygenation prior to endotracheal intubation, the panel issued a strong recommendation to use either high-flow nasal cannula or non-invasive ventilation to prevent peri-intubation hypoxemia. Finally, for post-extubation support, they suggest a risk-based strategy, recommending high-flow nasal cannula for low-risk patients and non-invasive ventilation for high-risk patients to minimize the need for reintubation following critical illness. Moving from non-invasive support to the most invasive form of life support, Intensive Care Medicine published a comprehensive review on the use of extracorporeal membrane oxygenation in patients with obesity. As obesity becomes increasingly common in patients requiring extracorporeal life support for severe respiratory or cardiac failure, clinicians face unique physiological, pharmacological, and mechanical challenges. The authors emphasize that obesity should not be considered a contraindication to veno-venous extracorporeal membrane oxygenation. In fact, retrospective evidence suggests that outcomes for these patients are comparable to or potentially even better than those of patients without obesity. However, the review notes that obesity-related respiratory mechanics can artificially exaggerate the apparent severity of lung injury. Therefore, clinicians must optimize conventional acute respiratory distress syndrome management, including appropriate ventilator settings and prone positioning, before initiating extracorporeal support. For veno-arterial extracorporeal membrane oxygenation, particularly during extracorporeal cardiopulmonary resuscitation, outcomes are more heterogeneous and heavily influenced by patient selection, comorbidities, and the timing of support. Success in this population requires specialized infrastructure, structured multidisciplinary protocols, and careful attention to cannulation, anticoagulation, and perfusion strategies. Next, we turn to the evolving landscape of diagnostic precision and infectious risks in the critically ill, where identifying the right patient and the right pathogen remains a major challenge. In intensive care medicine, the randomized controlled DigiCep trial evaluated whether adding metagenomic next-generation sequencing of microbial circulating cell-free DNA to standard of care microbiology could improve outcomes in sepsis. Conducted across 24 intensive care units in Germany and funded by the German Innovation Fund, the trial randomized 200 patients to the metagenomics intervention and 189 to standard care. The primary endpoint, which was the desirability of outcome ranking or response adjusted for duration of antibiotic risk score, did not show a statistically significant improvement at 28 days. However, the trial revealed several encouraging secondary outcomes. The intervention group experienced a shorter duration of mechanical ventilation, averaging 6.6 days compared to 9.3 days in the control group, and achieved faster shock resolution, averaging 6.9 days compared to 8.8 days. Additionally, health-related quality of life at 90 days, measured by the EQ-5D5L utility score, was significantly higher in the metagenomics group. While healthcare costs over 180 days did not differ in the subgroup with available claims data, these exploratory findings suggest that faster pathogen identification may translate to tangible downstream clinical benefits, even if the primary composite score was unaffected. This need for precision is further highlighted in a study addressing fungal infections. Writing in critical care, researchers conducted a multicenter retrospective cohort study of 492 patients across 16 French intensive care units to decode the clinical heterogeneity of candidemia. Using unsupervised clustering and factor analysis of mixed data, they identified 3 distinct phenotypes with vastly different 90-day mortality rates, which averaged nearly 63% overall. Phenotype 1, representing about 14% of the cohort, comprised highly immunosuppressed patients, mostly with hematological malignancies and high severity scores, carrying a 90-day mortality rate of nearly 73%. Phenotype 2, representing about 45% of patients, consisted of elderly patients with cirrhosis and early-onset digestive candidemia, showing a 70% mortality rate. Phenotype 3, representing about 41% of patients, comprised younger patients with lower severity scores and catheter-related candidemia, who had a significantly lower mortality rate of approximately 50%. Interestingly, while age, cirrhosis, and overall illness severity were independent predictors of death, severe immunosuppression itself was not. Furthermore, the use of an echinocandin and having a proven catheter-related source of infection were both strongly protective against mortality, cutting the risk of death roughly in half. This suggests that understanding these distinct phenotypes can help clinicians better risk stratify patients and tailor therapeutic approaches. While identifying pathogens is crucial, preventing healthcare-associated infections is equally vital, especially in trauma resuscitation. A retrospective observational study published in Critical Care analyzed data from over 55,000 trauma patients in a Japanese nationwide registry to explore the relationship between red blood cell transfusion volume in the first 24 hours and the risk of developing an in-hospital infection. The researchers categorized patients by transfusion volume into none, low, moderate, and high groups. The incidence of infection rose progressively across these categories, from about 9% in the non-transfused group to nearly 27% in the high transfusion group. After adjusting for confounding factors, even a low transfusion volume of 1 to 4 units was associated with an 85% increase in infection risk compared to no transfusion. Moderate and high transfusion volumes roughly doubled the risk of infection. A restricted cubic spline analysis revealed that this risk increases sharply at lower transfusion volumes and then plateaus at higher volumes. While the observational design requires cautious interpretation, it highlights the potential immunomodulatory risks of transfusion and underscores the importance of restrictive transfusion strategies where appropriate. Finally, we examine strategies to protect vital organs, focusing on hemodynamic targets, metabolic support, and the systemic burden of critical illness. In a major step forward for perioperative care, the HISTAP multicenter randomized clinical trial investigated the optimal mean arterial pressure target for high-risk hypertensive patients undergoing elective major abdominal surgery. Conducted across 18 Italian centers, the trial randomized 630 patients aged 60 or older with chronic hypertension to either a high intraoperative mean arterial pressure target of 80 mm of mercury or a standard target of 65 mm of mercury. The primary composite outcome of 30-day mortality and at least one major organ dysfunction occurred in approximately 49% of the standard group, compared to only 38% of the high target group, representing a 22% relative risk reduction. This benefit was primarily driven by a significant reduction in acute kidney injury, which occurred in roughly 24% of the high target group, compared to nearly 34% of the standard group. For hypertensive patients undergoing major surgery under continuous monitoring and protocolized fluid therapy, maintaining a higher intraoperative blood pressure target appears to be a highly effective strategy for preventing postoperative organ injury. Moving from hemodynamic optimization to metabolic support, a clinical guide. While traditional guidelines recommended high protein doses to combat catabolism and muscle wasting, 3 recent large international trials involving over 5,600 patients have challenged this paradigm. These trials demonstrated that higher protein doses do not improve survival or time to discharge and may actually impair long-term functional recovery. Based on this robust evidence, the authors suggest a pragmatic approach. Start protein delivery at low doses once the patient is hemodynamically stable and progressively increase it over the first 5 days to a maximum of 1.2 grams per kilogram per day. They note that patients with acute kidney injury may be particularly vulnerable to the adverse effects of higher protein loads. While higher protein doses might offer some benefit later in recovery once anabolic resistance subsides, the current clinical trial data support a safer, more conservative upper limit of 1.2 grams per kilogram per day during the acute phase. Protecting organs also means safeguarding the brain, which is highly vulnerable during systemic critical illness. A review in intensive care medicine highlights the massive burden of neurological complications in the intensive care unit, even in patients without a primary neurological diagnosis. Systemic stressors like hypoxemia, hemodynamic instability, inflammation, and metabolic derangements frequently manifest as delirium, stroke, seizures, or neuromuscular disorders. These complications are major drivers of prolonged intensive care stays, long-term cognitive impairment, and poor functional recovery. The authors emphasize the importance of targeting modifiable risk factors through standardized delirium screening, minimizing sedative use, and addressing environmental factors like sleep disruption and immobility. However, they also point out that wide variation in surveillance practices and definitions makes it difficult to estimate the true burden of these complications, highlighting a critical need for standardized research and monitoring protocols. If you only have time for one paper this week, make it the HISTAP trial. This landmark trial provides clear, actionable evidence that targeting a higher intraoperative mean arterial pressure of at least 80 millimeters of mercury in high-risk hypertensive patients significantly reduces postoperative organ dysfunction and acute kidney injury compared to the standard target of 65. Here are the key takeaways from this week in critical care. First, the American Thoracic Society now strongly recommends high-flow nasal cannula for acute hypoxemic respiratory failure and non-invasive ventilation for hypercapnic respiratory failure, with a clear risk-based strategy for post-extubation support. Second, in hypertensive patients undergoing major abdominal surgery, maintaining an intraoperative mean arterial pressure target of at least 80 millimeters of mercury significantly reduces the risk of post-operative acute kidney injury and organ dysfunction. Third, clinical trial evidence suggests we should avoid aggressive protein dosing in the early phase of critical illness, starting low and capping intake at a maximum of 1.2 grams per kilogram per day, particularly in patients with acute kidney injury. Fourth, while metagenomic sequencing in sepsis did not improve the primary composite desirability of outcome score, it showed promising secondary benefits, including fewer days on mechanical ventilation and faster shock resolution. And finally, red blood cell transfusions in trauma patients are associated with a dose-dependent increase in post-injury infection risk, even at low volumes, reminding us to remain judicious with blood product administration. That's your roundup for this week in critical care. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.